Started. Um, Welcome this afternoon to our third session of the Diabetes Continuum of Care, Developing Patient-Centered Resources for Diabetes Care. Next slide, please. As you know about this learning collaborative, we're really trying to focus on diabetes because it is, as we understand, a growing issue. In America, we know that diabetes is affecting more than 34 million people in the United States. And so this learning collaborative, along with other learning collaboratives that are being conducted by the 14 national training and technical assistance partner organizations, are important to try to help health centers in addressing and other individuals and organizations addressing this public health issue. Next slide, please.
Sorry, 1 second, Darlene. It seems like someone is saying that they're not, their audio isn't working. Is that the case for others who are currently on? And maybe that's a question to put in the chat.
Oh, I see Wendy saying no audio. Can Fatima, can you hear me? Javita, are you able to hear?
It looks like Javita is able to hear us. Fatima just joined.
I can hear you okay, but I'm not sure. Always check your speakers and volume and whatnot, but
Okay, yeah, Javita's saying yes. Oh, okay, great, Wendy. Glad you're able to hear us now. So this is just, this shows you the 14 special and vulnerable population task force members. And so we all have come together to plan these different learning collaboratives during these this month. And I'm not sure if some go over to next month, but we know it started last month and they were in February and continuing on. Next slide, please. The faculty for today, and we're going to hear from Jillian Bird, who is the Director of Training and Technical Assistance at the National Nurse-Led Care Consortium. So we're very, very excited to have Jillian lead us in our discussion this week. And as you can see, our other faculty that are here today, I'm Darlene Jenkins. We have on the presentation today, as well as Alexis Guild, and then also Sabrina. And we want to just give a shout out to Lauren, who has helped us. She is unable to join us today, but she has contributed substantially to this presentation. So we want to make sure that we recognize Lauren's efforts as well. Next slide, please. So this is just letting you know where you can find our resources. So this is the recording of these sessions as well as the PowerPoints. And so we do have a website that you can go to and you can access everything that you hear as well as that you can see. So make sure that you do check these things out. They're found at chcdiabetes.org. So please make sure that you go visit this website because that's where you can find resources. And if indeed you have questions, please contact us at the email that is given below with the training at chcdiabetes.org. Thank you. Slide. So this are the learning objectives for our session. And Jillian, I'll turn it over to you as you get us started off in this session for today. Thank you so much.
oh, thank you. Thank you everyone for joining us. And thank you, Darlene. These are our overarching series objectives. In our last session, if you were able to join us, Darlene walked us through with our guest the impact of implicit bias and how that serves or doesn't serve, but it is an impingement and a barrier when you're interested in creating patient-centered resources. And also we touched on understanding how cultural humility may be a facilitator to engage patients in diabetes care and the development of resources. And then we also are generally discussing identifying strategies and improving patient engagement, particularly when in development of resources, but also in that continuum of diabetes care. And so we'll be touching a little bit on some strategies and some tools that are have been utilized in the clinical care setting to help amplify and facilitate patient engagement across all populations. And as we go to our next slide, this is just a reminder. Oh wait, do we have a Mentimeter slide? I was going to bring up the Mentimeter slide, but we are going to be utilizing Mentimeter in this session. And when you see the Mentimeter slide come up, this is an interactive tool that's very simple to use. You can use your cell phone or open another internet browser. And then you'll go to menti.com and enter the code that's at the top of the interactive slide. So you'll see that when we get to that. But moving on to this next slide, we're really going to be touching a bit on digital health literacy. It's similar in concept to health literacy. That is that ability for the patient to access and comprehend the HIT, the health information and those services. And digital health literacy really encompasses a number of skills, which includes computer literacy. For example, if telemedicine isn't properly arranged, it can actually end up exacerbating gaps in health disparities. So, you know, we've had such a tremendous pivot with COVID into the adoption of telehealth. And what it revealed was that, you know, if done in a way that isn't thoughtful around digital health literacy, it can end up exacerbating those gaps. It can exacerbate disparities in access, disparities in outcomes. So, and, you know, as we understand technology and its array of capabilities to measure data and manage information and automate processes, and it's really plays this integral role in healthcare these days. But we now want to try to build that other part of the bridge so that our individuals, our consumers, our patients are able to engage with their healthcare as we're developing more and more technological interface. So we do want to make sure that we're considering computer literacy as we're developing our HIT and our digital health interfaces. As we go to the next slide, there was a digital health literacy that was published in 2019, so just prior to COVID. And this cohort study was, you know, close to 150,000 patients. And even then, what was found was that older individuals with Asian race or Asian American and the primary language other than English had fewer completed telehealth or telemedicine sessions, including phone or video, as compared to the other patient population being served. And in a second study that did overlap the impact of COVID, there was a reported lower video use in households with lower income, Latinx households, Black households, and households with an older age population there. So depending on the population being served, you know, we need to think that telehealth isn't the answer, or telehealth could not always be the answer that folks are looking for. So, you know, one of the things to consider is that we're ensuring that health literacy for all, that we're thinking about how we're utilizing our team to help when we need to orient people to using the available technology. Also, what is the aspect of patient engagement? So how are we inviting our community in to help us design those tools that we're using and evaluate and assess them in action or in operation? We also want to be considerate of the resources that we have available and how are they being translated, not only for languages other than English, but also potentially for individuals who have impairments in their sight or in their hearing, certainly considering all these population considerations. And on to our next slide. So there are three areas that really sort of rise to the top when you're thinking about the challenges with digital health literacy. That can be the absence of technology. So just households or individuals who are unable to access technology. And, you know, in this day and age, when we think that everybody has a smartphone or everybody has a computer, there are still individuals who are not utilizing technology in their day-to-day life. They might find that they could go to a library and use a computer or have access in some way through a community center or something of that nature, but it's not theirs, it's not in their responsibility, and they're not acculturated to be using in their activities of daily living some type of interface with technology. That's maybe something that we're not always considering. Another challenge is really reliable internet access. So it doesn't have to be that you're, you know, in a rural setting that you don't have reliable internet access, but we do know that there's a variety of locations still around the country that have no broadband internet service. Many parts of the Midwest and Western parts of the country that are more rural, there's significant numbers of individuals whose households do not have broadband. So I think it's 1 out of 7 I was reading in Wyoming. But and what surprised me was even in you know, parts of Louisiana, and you may not think about this being an area of internet kind of desert, but you know, 1 in 4 households in the state of Louisiana had unreliable broadband access. So if we're having so many of our services pivoting to internet relied upon access, those folks are being marginalized from that opportunity. And with a lot of the diabetes prevention plans, you know, a lot of that pivot has moved from in-person group settings to online kind of group Zoom meetings to walk through those prevention plans together and support each other in those settings. And there's been, you know, a significant challenge, not only for recruitment, retaining individuals in those settings, you know, because there's a lot of hurdles for folks to manage, to be able to engage in that virtual way, in a meaningful way that works well with their life. One of the reports we'd had too is that folks are feeling very isolated. So although they might have access to group settings or support groups in some way through Zoom, it's not as appealing to them. It doesn't bring them the same reward. It doesn't provide them the same counsel and peer support that they would otherwise be getting. And so that's another thing I think to consider, is that we have this kind of fatigue happening across this utilization, there's so much utilization of virtual settings. And then finally, this digital literacy piece is, you know, really important, just really understanding even how to navigate on a computer or on a smartphone, on a tablet, how to engage with the Zoom platforms or the Google groups, or, you know, there's such a variety as well. And every one of these platforms has their own little, you know, tweaks and differences. And so how are we supporting our individuals, our consumers, our patients to be able to, you know, navigate not only their schedules, meet those virtual appointment times, but then like log in through the portal and then access the message that comes up. And, you know, there's just a lot of intricacies. So that digital literacy piece is really keeping folks from being able to engage meaningfully with their care. You know, and then it's kind of like, what's this going to mean for our health centers? It's another responsibility, right, that falls onto our care teams to help our folks be able to successfully navigate all of this. It's kind of like one more thing, right? But it's a really important thing. We're not returning back to the age pre-digital. We're sticking with it. So, you know, when so many providers are now working certain days from home, and their whole panel they're seeing in telehealth, we need to make sure we're not losing anybody in this transition. So going on to the next slide. So this would be, I hope, where our Mentimeter question comes up. If it's not coming up for us in Mentimeter, it'd be great to hear from folks. What would you say is the most common health literacy challenge that your patients are facing? If you can, maybe we can advance to the next slide and see if the Mentimeter is there. If it's not, then, okay, no. So I think if you can share with us in the chat, what would you say is the most common health literacy challenge your patients are facing? And that could be either the absence of technology, so they don't have smartphones, they don't have tablets or computers, they do not have reliable internet access. So one of the challenges is they're not able to really access that good broadband internet, or they are lacking, or they're struggling with digital literacy. So of those three, what would you say is the most common health literacy challenge your patients are facing, your consumers, your individuals? No internet. So Kelly's sharing with us, no internet, bad connectivity. It's great to see you bringing up translation services. So we're going to talk a little bit about these language services. And then older patients who aren't used to using technology like this, right? There's such a preference for just getting on the phone. And then Javita is sharing that a lot of our patients are migrant workers. And so there is a set schedule, and that is definitely a technology challenge. So you're not able to, oh, there's not a set schedule. And it's very hard to make an appointment, right? If you're relying on being in a place where you can access the internet and you can be maybe quiet and secluded to share what's going on with you, but you're in the middle of your workday. I mean, that makes it very, very difficult, obviously, if you're working out of doors and you're working around a lot of people. And then Wendy's sharing this inability and hesitancy to use technology. And so the comfort zone there is really relying on audio. And meeting people where they are is so important, but as we know, it's also keeping a lot of people from not wanting to engage in this way. So we can move on to the next slide. This is really just a little talk about the digital divide. And this is just a little information around, some of what the reality is for our general United States population. That, for example, more than 1 in 3 US households headed by persons 65 or older do not have a desktop or a laptop. And more than half do not have smartphone devices. And another, kind of point to piggyback what I was saying before, a lot of folks, 1 in 5 Americans older than the age of 50 are really suffering from social isolation. So we might feel like, oh, we'll just ask a friend or ask a family member to help you navigate this. A lot of folks really do have that sense of isolation. And if they're not able to navigate it themselves, they don't feel that they have anyone that they can rely on to help them navigate through this. 52 million Americans report they still do not know how to use a computer properly. And I mean, there's so much complexity to computers. I use them every day, but there's still a ton about a computer that I'm still ignorant of. I just don't use it to its full capacity. So that's not an uncommon situation for someone like me who's engaging a lot with a computer. This is still, kind of a foreign territory for many folks. And then individuals in the older age bracket and Black individuals and patients are less likely to use the patient portal. I don't have this site, I don't have this reference cited, so I apologize about that, but I can provide that again. And then we did talk a little bit about that rural access, the lack of broadband internet. So just having an idea that we can sort of address some of these things by understanding the populations that we're serving and be really direct about it. And we can move to the next slide, which is about kind of bridging that digital divide. Really creating the digital health equity as a priority, like bridging that health equity, that digital health equity, really making that a priority within your organization. Really want to invest as much as possible. That might be, the human time, it might be fiscal, but investing in these innovations around the multilingual digital health technology. So do we have the possibility of providing kind of IT support to our patients across multiple languages, walking them through getting onto the portal? And that might be something that's kind of subcontracted or part of your EHR contracts. It might have to be a third party, but spending some time looking into what does that look like. Also, allocating resources for multilingual digital health support. So does the help desk or the call center have multilingual folks to answer the phone? Do we have texting capability, or is there multilingual video visit capability to ensure that families that have emerging English speakers adequate information about the platform that they're going to be using? So we just want to invest some time in that, preparing the individual's family support and how they're going to be navigating through some of the technology and listening to what they say are some of the digital literacy differences or gaps there. So, really another great thing, this is really speaking to patient engagement, is creating opportunities for community members to give input into what does the virtual care look like. And everybody sort of launched their digital care rapidly and in response to COVID, understandably. Maybe it wasn't always the most patient-centric, but now as we can take a step back and think about this being a durable and sustainable way to interface, like asking the community members to come in and comment, be involved in some of the planning of, rolling out the next phases of this, will be one way not only to engage your community into this, but also to, be mindful of our blind spots. What are we not seeing? What's important to be addressed that we didn't notice before? And so again, also thinking about user-centered design, and when you have a user-centered design, but it's really maintaining kind of an English-centric or a certain population-centric perspective, a lot of people get missed. Their abilities, their strengths, what they're most comfortable with gets mixed in that. So really trying to use that sort of multilingual, multi-language, multicultural perspective when designing that user-centric type of decision making, and how are we going to actually operationalize this? And on to our next slide. Oh, and a portion I forgot to mention is the data collection, so having equity and thinking about equity when collecting data analytics is another area to be thoughtful of. We want to continually improve our accuracy and the consistent collection of demographic data, but also doing it in a way that is acknowledging equity as we do it. Okay, so it looks like Mentimeter is coming up, but maybe they're all together. So let's go on to the next slide and let's see. Okay, great. So in what ways? Yeah, so we want to go to menti.com on your phone or on your browser. Then there'll be a code that you can enter, and it is here, 6947-0437. And when we are talking about ways, really active ways of bridging the digital divide, if there's some that you can think of, like what are some of the ways that your health center is addressing the digital divide? And you can just type your answer in there and we'll see kind of what is happening out there in the world. Any answers coming up yet? You can also put it in the chat, which is perfectly fine. This is a whole new area of technology, right? So we're using another form of interface. We're all having to pivot quickly and pick up phones and do this and that. So it may not be appealing, and that's absolutely fine. Okay, so no answers there. That's fine. Let's go on to the next. Oh wait, no, there are answers. Huh. Lots of answers. People are typing. Woefully lacking throughout our hospital system, unfortunately. All of the suggestions given here to bridge the divide are appreciated. Okay, provided how to use Zoom presentation. That's great. That's really important. You know, Zoom is sort of where we're existing these days. And I think if people aren't feeling like they can even speak the language, it definitely excludes them from the conversation. So giving that information is very helpful. Oh my gosh, and sending community health workers to in-home visits and having them set up tech. That's amazing. What a great, gosh, I mean, that's just such a like supportive and really holistic way of addressing this. I love that. I love like getting into their homes and really troubleshooting with the individual. And it's ongoing, right? I mean, I'm not sure about you, but many of us, I have many aging relatives, and you know, often it's the same problem that comes up. It's like I get the phone call and it's like I need help with this, and it's really mirroring a lot of the same challenges that, you know, I've been called to help with before. So sometimes it's not, you can't just do it once either, you know, really kind of establishing that relationship, that trusting relationship, that it's okay if you don't remember how to do it, or it's okay, it didn't work for you this time, let's walk through it again. And that really requires that established trusting relationship that, you know, so many community health centers are known for. Bringing that community health worker in, it's such a great bridge building opportunity. It's really awesome. Thank you for sharing those. Okay, let's go on to the next slide. And this is just to kind of bring in the legal implications or the legal imperative to, you know, really be addressing language access and providing. It's an important part of our care delivery, and it's actually a requirement for any entity that's receiving federal financial assistance, such as Medicare, that we must be taking reasonable steps to provide meaningful access, to programs by persons with limited English proficiency. So individuals that might be, having either English as their second language, or they're emerging with their language use. Nonetheless, it is on us as an imperative, and it was redefined again in the Affordable Care Act to have, language access, something that we are addressing in locations that are receiving federal financial assistance. So moving on to the next slide, one of the ways that this is really addressed is by creating a language plan. We understand that effective communication is critical to providing high quality care. And it's very common that people rely on family members or friends to kind of do that translation. But what's most preferred is to have qualified individuals interpreting medical information. We know that, reliance on unqualified individuals can lead to misunderstandings. It could really lead to diagnostic errors, poor outcomes. So addressing kind of how to tackle this, one way is to develop a language access plan. And it can ensure that your organization is considering what does it mean to provide high quality, appropriate language services. And it can also ensure that the organization's staff, all of the members, are aware of what to do when there's an individual with limited English access or proficiency, and they need assistance, including how to talk to them, how to talk to them appropriately, how to, help them feel welcome and that their needs are being addressed. That's a responsibility of the whole care team, of the whole organizational staff responsibility. And really anybody, any organization that's serving individuals with any limit on their English proficiency really needs to consider developing a language access plan. And then of course we know those that are receiving federal funds, it's a requirement, not the plan, but the plan will help you address the access. And so this is kind of how it's broken down, and we'll go into this in a little more detail. Developing a needs assessment, looking at what are the communication needs in-house. So really enumerating all of those services offered. How are you going to notify your patients that these services are available? And then the training, and to really ensure that the staff understand how to guide patients into receiving those services. And then obviously everything, we need to reevaluate ongoingly with metrics to make sure that we're actually meeting the needs of our population. So we can go to the next slide. I think it might be a little bit, it might be a Mentimeter slide. Just asking if your health center has a language plan, either that is developed and utilized, or is maybe in consideration to be used, or not at all. And I don't quite know what our participation number is, so we may not have a lot of answers to expect. More yeses than nos. Or not sure, if you're not sure if you have one. That's great. And okay, no. And this might be, a question to bring back to your organization. Perhaps it's not that the plan is there, but there's definitely like the infrastructure is there anyway. But a plan might help kind of give you a place to sort of do a quality improvement evaluation. How are we doing in this plan? Does everybody know about this plan? Great. Super. Thank you, everyone. And we can talk a little bit more about this plan a little bit moving forward. But just to break it down, actually, can we go forward to the next slide? And then we'll come back to this. So this is the parts of the language plan. We've got, like I was mentioning, the needs assessment. It's really that, you know, you can rely on the useful internal data that you might have, like your call centers, the information that you might be getting from your patient navigators, your electronic health records. You want to be pulling that information in to help with your needs assessment. Do you have any publicly available resources that might give you an idea of the demographics of the individuals that your organization might be serving? So if you don't have that internal data, you could look towards the external data to help give you sort of a sense of what your patient demographic is. And then considering the points of contact, like at what point are you going to be potentially coming into encounter with an individual who may have limited English proficiency? So like your call centers or the registration, your mailings that go out, if you do mailings, or your website, you know, places where they're interacting with your organization, might be outreach programs or information lines, the website again, and you might also consider your stakeholder engagement. You might be giving, asking for feedback from community-based organizations or patient satisfaction surveys, and that can kind of all inform your needs assessment. The next part of the language plan is the language services themselves. So then it's building out, how is your organization going to provide interpretation services? How are they going to translate materials? You want to consider addressing the interpreter training and qualifications. So is there a metric there? Do you have a minimum level of competencies, or are you using a contracted organization to make sure that you have high quality trained and qualified individuals for translation or interpretation? And then, you know, translation might be, you know, all of your written communication, some of your written communication, like which are the more vital pieces that must be translated appropriately for folks to attain the services at your organization. So that would be another place, another portion of that language plan. The next part would be the notices, notifications to the patients that there are other there are opportunities for interpretation or translation. And some of those things would be creating I speak cards, which have you know, it says I speak, and then there's maybe 14 languages listed, and there's a chance to highlight the one. The individual can carry that around and show when they get to the health center. There may be notices plastered around the organization. So again, it's like the same information is there, but translated numerous times into various languages, which give the information about the interpretation number, you know, the number to call that interpreter, or it can help someone to be able to point to that's the language that they speak, and hopefully it's a multilingual interpreter. And then also, you know, just potentially having your care team be a representation of the community that you're serving. So you have members of your care team that are capable of interacting in that primary language, that first language of the community that you're serving, so that there's, you know, right away the staff is able to communicate proficiently with the individuals. The fourth part is training. Obviously, we've talked a little bit about this. Really want to make sure that people who interact with individuals are aware of how to support them. They want to be able to be, you know, they should know after their training why it's important to have interpreter lines, language assistance services, and then also just really feel comfortable communicating effectively and respectfully with individuals who may not have the English proficiency that, you know, someone might feel more comfortable with, right? It's also a place to consider reviewing your policies and procedures. and that data collection and helping that define in your policies and procedures when interpreters should always be used. And what do you do if you just have a patient preference on certain areas, which ones are vital for interpretation and which ones, may not be as important, but certainly always recommended. And then finally is that fifth portion is the evaluation. And that's that monitoring and continuous improvement to ensure that this plan is working. It's working for the organization and for the patients served. So I think if we can just bump back to that last slide, you can ask folks, what stage is your health center at in its language planning? Have you gone through, have you completed your needs assessment? Are you through to communication? Have you finished with training? Are you doing all 5? I don't know if you could answer more than once, but actually, you can also list it in the chat if you feel like you've accomplished, if you have more in that than just the one. Okay, great. And thank you all to all of you that are responding. When you're doing your training, is it curious about how you're conducting training? Those of you who are answering there, or you're maybe in evaluation as well. Is that something that you're doing kind of in your all staff training? Is it like an all staff meeting? Is it like little parts of your daily huddle? Like, how do you break that training out? Is it on self studies? So your self-paced modules that you have to do on your own time? Kind of curious how people are conducting their trainings. Oh, that's great, Barbara. So Barbara writes, we've been working on different strategies to address language barriers at our hospital and are in the process of creating a language committee. And Barbara, what is the community? Where are you located? I can see part of it on your name, but not. Los Angeles. So, and then Wendy's written part of orientation, which is great. Self-study modules when hired and annually. Great. And Kate's writing, we have a company-wide annual trainings that are required, but no good on-site resources, additional staff training. So I indicated communication needs. Yeah, it's hard. It's those big landmarks are easy to kind of tack on these trainings, but that like ongoing upkeep can be really, really challenging for folks. So just for the considerations of time, we'll move on. I just had a couple other tools to kind of, to share with folks around patient and family engagement. And this is one, shared decision-making. It's really been defined as, it's evolved from a ethical question into a clinical kind of practice area. It's very accepted and promoted approach to working with our patients and our consumers, individuals. And it's, really bringing the patient into the process so that the care decision-making is part of the patient's responsibility, and not as sort of a new thing, but sort of as an expectation, as a something that is like the baseline assumption. And the optimal decision takes into account the evidence-based information. So that's where our provider perspective comes in. But it's also really aligning that with your individuals, your patients and consumers' values and their preferences, which may diverge from what's the recommended course of treatment. So going on to the next slide, this is just from AHRQ, and this is the Share Approach to Decision-Making model. And a lot of the AHRQ resources can be found in multiple languages. This is just more of something to hang in your, like a poster, to remind clinicians to kind of walk through these 5 steps of seeking the patient's participation, helping them explore and compare the treatment options, assessing their values and preferences, and then coming to a decision, reaching a decision, and evaluating your patient's decision as you move forward. So each encounter is an opportunity to evaluate and redesign that course of treatment. So just want to mention AHRQ's, Share Approach. I think it's a wonderful guide for shared decision-making. They have a lot of tools that you can give to individuals to fill out on that. We can go to the next slide. This is just the tips to help providers with shared decision-making. And it kind of lists some of what's on the share model, but just breaks it down a little bit more. For example, really leaning into motivational interviewing, really asking open-ended questions, helping by the nature of those open-ended questions, it helps patients evaluate options based on their goals, helps them deliberate and come to those decisions themselves. So they're feeling like they're autonomous in that decision making and not being given directives on how to take care of themselves. So really leaning into those open-ended questions from motivational interviewing. We can go to the next slide. And this is another AHRQ tool called Be the Expert on You. And this is highlighting some of those preferences. So you can see the top question, why are you here today? Again, these can be translated, and many of their tools are translated already on the site. This is all public use available. So folks can check here and use this in their clinical encounter as an agenda setting tool. So why are you here today? Being able to write down what are the concerns they have. Has there been a change in how you're feeling since your last visit? Have you seen anyone else about your health? So sometimes that continuity of care gets really derailed if folks are seeing people without letting their primary know about it. Do you have any questions? And then what are you worried about? And sometimes that last question can really help inform the direction that you want to take that, that treatment plan, for example. If they're really worried that, the medications might not allow them to spend as much time with their grandchildren because it makes them drowsy, then you can have a conversation about medication modifications, for example. But you would know that if you're not concerned or you're not aware of what are their primary concerns. And then you go to the next slide. And what this strategy does is it looks at this tool that the patient brings in to the clinical setting. We could go to the next slide, please. And then it asks the provider to do 60 seconds of active listening. So the idea is that we use that tool for the patient. They come in with that tool, they filled it out. The provider is asking these questions and then listening for 60 seconds. They listen, they encourage the continued story to be told, they write notes, have eye contact, and after 60 seconds, uninterrupted, they're able to move into a more clear understanding of the next steps of the diagnostic process. So this is a really amazing tool. I think the benefits there, it's shown great engagement, from individuals who've been working in this way. Patients really appreciate it. They feel listened to, they feel heard, they feel like they're part of the process. So I encourage you to consider this AHRQ tool. And then moving on to the next slide is getting patient feedback. So this is another way of evaluating your language plan, the way that you're utilizing translation or interpretation services, is to get feedback or to go through the experience. So maybe shadow patients. One staff member can shadow and observe, what does this patient encounter as they're going through our care setting. You can have a walkthrough with an unfamiliar person. So someone from outside the organization kind of walks through what it would be like. And you can find these opportunities where, there's some language breakdown, or there's some, some gaps in access to literacy here. So how can we fill that at certain points in that patient interaction? Have a moment where someone's just observing how a patient is navigating through the patient portal, providing feedback forms, suggestion boxes. And, we do a lot of surveys of patients, but that's another tool. And then obviously we want to see how can we act on these results. So we can go to the next slide, which I think is the last slide. And then I'm just curious, how are you receiving patient feedback? Are you relying on shadowing? Do you use surveys? Are you having observations? Some of the ways in which your organization receives feedback from patients. So patient experience surveys are interesting to me. Would you consider that to be different than patient satisfaction? So is that like those classification of questions are more about the way that they are navigating through your healthcare center? Surveys?
Barbara,
Yeah.
about the patient experience surveys, and they are very similar because we want to know is about their experience, the good, the bad, and the ugly.
Mm-hmm.
So yeah, so it's pretty much, and they can always as well contact our patient experience manager directly. So that's another option.
That's
And
great.
we also run on the patient, so that's definitely another way to get their feedback.
And folks, you feel like they're comfortable providing that level of feedback? So there's a patient satisfaction and experience surveys, and a patient excellence program where patients contact them with concerns and issues. That's really interesting. So it's giving them this direct access to have any grievances addressed. Is that in the hospital setting, or is this in a community health center setting? Oh, great. That's awesome. Very good. Thank you, everyone, for, okay. Oh, a patient advisory board. Yes. So important. Okay, hospital setting. Yeah, our communities know so much, right? When we can tap into that resource. We can move on to our next slide, which is just some resources, and wanted to open up the floor if there are any questions, or if anybody would like to share any more about the ways in which they are addressing language access within their care settings. Please feel free to unmute or to share in the chat. So again, oh yeah, go ahead, Barbara.
Yes, Jillian, in terms of community health setting, which is what I oversee our community health department, our programs, well, we are in downtown Los Angeles. So our area is mostly Latino and African American. With that said, our programs are either in Spanish or English. We try not to do both because there's that disconnect and lost in translation. So we are, another thing that we do is we go into the community. Of course, we have programs at our hospital, but we like to go into the community because transportation is another barrier. So we go into schools, we go into community centers, we go into churches where our audience, where our patients, where members are at. So, and also our material is in Spanish or English as well.
Thank you. Thank you for sharing that.
Hi, this is Wendy. I know I have another meeting at 1, but really quickly, we have the large hospital system that serves the underserved, of course, in the community, and we have mostly Spanish speaking, and as far as our other language besides English for our population. And I don't find that we have that many issues with the language part. We've really been better about signage. We're building we've built multiple new facilities, inpatient and outpatient. That inpatients in process still, but multiple ambulatory clinics are being rebuilt, and the signage is all really sharp and I think really reflective of what the patients need. But I find that we're really lacking in terms of health literacy, just overall gearing our materials to the patient's level of understanding. What English speaking, non-English speaking, just making it, meeting them at their level of understanding. I don't think that we're there. We have a long way to go. And a lot of times we do have, I'm part of the patient advisory, the educational advisory committee, and they don't, they let a lot of stuff slip through because it's submitted by upper level management or, this medical directors or whatever, and they just slide things through, which I wish was different. We need to change that.
Some of the resources on the one resource slide might be of interest. There's a lot of, there's certainly these applications that you can run your information through and it kind of breaks it down, but those aren't always the most reliable.
No.
Really using your community resources to help, maybe your community-based organizations or another way to kind of evaluate the utility of those.
I know it makes it really hard though, because a lot of the different departments will submit materials that are not that aren't already developed within the system, or that we get from the CDC or other organizations. And even some of those, the literacy level is college level and everything. So it's difficult. We have to figure out what's an efficient way to evaluate those that come to the committee in order to, with the multiple tools that are out there to do it effectively. We're not experts in that. And so it's difficult to know how. I don't have the answer.
Well, next week we have an opportunity to develop and really have a discussion about kind of parsing these large undertakings down into small bites and developing a little bit of a strategy around accomplishing those. So I feel like it'll be a good time for us to pull ourselves together, brainstorm a little bit about these, actionable steps and small ways in which we can start approaching some of these larger complex issues. So I know we've gone over, but I just do want to invite everyone to come next week. Bring these ideas that you'd like to see into fruition, and we can walk through ways in which we can start to create a plan of action and share some of the strategies that we've seen have been successful, and do a little bit more peer sharing next week. And I just want to thank everybody for taking the time to complete our poll here and for spending this last hour with us. We really look forward to our next session. That will be our last session next Thursday at the same time. Please reach out with any questions, refer to our resources that we have on the website, and I hope you have an enjoyable rest of the day. Thanks, everybody.